much for that introduction. So everyone's like, wait, are you at UCI? Are you at Radiant? Where are you at? I'm at both places. So I will do teaching here at UCI. I love teaching. And then I will also see patients and do medical directorship at Radiant Health Centers. And I see some familiar faces here for Radiant. Can you raise your hand? You're here? A big representation. Thank you all for coming. And then I have my UCI friends too. There she is. There they are. Thank you for coming. So my topic is, I think, the coolest topic, right? So PrEP is, I'm very big advocate of PrEP. And how many PrEP practitioners do we have in the audience today? Yes, we love PrEP. PrEP changed our life. PrEP changed our patients' lives. And I also wanted to take this time to thank the industry partners who have put in so much time and so much effort in bringing these amazing products to our patients so we can end the HIV epidemic. With that, I want to start. Let's do this. All right, so I am a consultant speaker for VEEP GSK. And these are my objectives. So we're going to describe characteristics of current and emerging PrEP options plus other biomedical options, and we're going to talk about some dosage, forms, and frequency. In the overview section, I will talk about the available oral and long-acting antiretroviral options for HIV PrEP, focus on the data, safety, efficacy, durability, and then implementation, which is an important part of PrEP practice. And I want to focus on primary care providers today, and we're going to try to talk about how to identify patients for PrEP, eliciting a sexual history, lab monitoring, etc. And if you want to ask a question, if you want to wait till the end, you can do that, or if you can, it's up to you. I'm flexible. All right, so let's talk about this slide. Let's talk about some numbers. So this is the HIV.gov 2021 data. So in this, you see that U.S. government had very ambitious goals for the HIV epidemic in America. And the goal was to have 75% reduction in new HIV infections by 2025, which is this year, and at least 90% reduction by 2030. Where do we think we are in 2025? Numbers, anybody? Not close to 75, right? So how were we gonna do this? We were gonna diagnose patients as early as possible with HIV. We're going to treat the patients with HIV as soon as possible and suppress them, so treatment as prevention, as it was talked, Dr. Dar talked about it. And then we also wanted to prevent new HIV infections by introducing PrEP and screening services programs. And then we wanted to respond very quickly to potential HIV outbreaks when we do see them happen. Those were great. Well, what happened? Well, you guys know what happened. All right, I'm not gonna spend time on that, but I'm getting a little agitated. There's a lot of defunding in those areas that's going on, and we're not close to the goal. So that's why we have more work to do, and we're gonna continue to do that. And then why we wonder is like, why PrEP? Why can't we just have HIV treatment and treatment as prevention? Why do we need PrEP? This slide answers that only 51% of people with HIV are virally suppressed. We have more work to do in that area, but also we have another option now, which is called PrEP. So I call it my plan B. PrEP is a plan B. So these are the CDC estimates. I won't have very cute pictures like Dr. Aina Park had in her slide set, but we'll have some data, but I'm not going to show you some of those pictures because our work starts before patients develop HIV, and she covered the ACIs so beautifully, so I'm going to leave those pictures to her. Also DoxyPap, but I want to spend like a few seconds on DoxyPap. Just do it. Just do DoxyPap, and that's just part of the PrEP for me too. The HIV PrEP and DoxyPap, they go hand in hand. So what does the CDC estimates show? So we still have more than 31,000 people turning HIV positive every year in the United States. Are we surprised by this number? And then, what's the disproportionate thing that we see here is that 2.2 million Americans could actually benefit from PrEP. So imagine if we had these 2.2 million people on PrEP, that number would definitely be lower, and that was the original goal of ending the HIV epidemic as well. But how many of them are actually getting PrEP? 18.1% of that US population is actually at risk, is actually on PrEP. That's where the work is. That's what we have to do. Not even 20%. We are not even 20% PrEP positive in these patients. So, what are some of the reasons? Knowledge of PrEP among patients is lowest in African American population, women, and Hispanics. And these are actually disproportionately affected group of who are getting HIV infections. And then the uptake is also lowest in these populations. So 4% of women at risk are on PrEP. And how many, just give me a number, somebody. How many cis women get HIV infection? What is the proportion of women out of, say, there's 100 patients who are HIV positive. How many of them are women, cis women? Anyone? 20% of new HIV infections are in cis women. 4% of women at risk for those HIV infections are on PrEP. We need to think about cis women when it comes to PrEP. So what can we do? So increase knowledge among the affected groups, increase patient access with more healthcare services sites of providing PrEP. And I'm thinking like everybody who's here, every organization who's here is offering PrEP, right? Is there an organization who doesn't offer PrEP? Great. So I'm educating people already aware of this. That's great. But we gotta spread the word. We gotta educate other centers, other people who are not doing this, primary care providers especially. PrEP is something that primary care providers can do. It's not an IT thing. So let's do that from now on. And this is why provider PrEP awareness is very important. So what are those numbers, right? So 76% of primary care providers are actually aware of PrEP, which is good. But only 28% of them are prescribing PrEP. So there's a little bit discrepancy in that. So what is happening from when they know about PrEP to when they're actually prescribing PrEP? So this was a low estimate that was done on PrEP coverage for the last decade. From 2012, that's when the oral PrEP TDF FTC came out and was the first agent for PrEP, to 2022, the mean PrEP coverage across the US increased dramatically from 0.6 to 26.3, and HIV diagnosis rates actually decreased, but only modestly from 13 to 10. So per 100,000 population. So even though the PrEP uptake was higher, the number of patients getting HIV actually wasn't that much different. And then proportionate decreases in HIV diagnosis were higher in states with higher PrEP coverage. Nothing surprising about that. The more PrEP you use, the lower the HIV incidence. And what are the current coverage rates of PrEP? CDC is still working on it. They might be working on it a little bit longer than we think, because they haven't updated anything since earlier this year. I wonder why. Okay, all right, so let's talk about taking a sexual history. How many of us are comfortable taking sexual histories? It's part of our practice. All your EPIC charts have sexual history documented. I know at Radiant we have, our MAs do a great job initially with the intake, and I was actually, when I saw a patient recently, was making sure that I look at the SOGI and I look at the sexual history, and they were done. So it starts from the first visit, right? We have to introduce sexual health, sexual wellness, sexual health history from the very first appointment. And we have to create a patient-safe environment, confidentiality. We have to be non-judgmental, be sensitive, and a matter of fact, and avoid assumptions. We can't assume somebody because of their age or demographics that they're sexually active or not active. Ask everybody. So take a sexual history from all patients. If there's one thing you take from today's talk of mine, is that we gotta get better at taking sexual history, and we're gonna take that. And then we are aware of the CDC's 5 Ps. Very important, kind of like a little cheat sheet guideline to take the sexual history. So you're gonna talk about the partners, past history of STIs. You're gonna talk about, if they have risk of repeated infections, and number and gender of partners over a given time. You're gonna talk about what other STDs we're concerned about, or we talk about is the HIV, herpes, gonorrhea, chlamydia, and I would add BV to that, if Dr. Ina Park is okay with that.
Yeah.
I would consider STI to add BV to that mix as well. And then, so whenever they had STI, or is it in the last, so CDC says in the last year, and I would say like if they ever had an STI, they're at risk, right? And then also we're adding the HPV trick, and then last HIV test. We should always ask about the last HIV test. I've always worked in organizations where we do the HIV testing every year, if not more frequently, especially at the entry. And so if you're not doing HIV tests on all your patients, just do it. Practices, sexual practices, we want to ask about that. The stigma of asking for sexual practices, oral, vaginal, anal, we should not have that anymore. I mean, this is 2025. Ask about, if you don't ask, they're not going to tell you. Ask about all the sites. Practices of pregnancy, desire of pregnancy, and use of contraceptive methods. This is versus women. And then protection from STIs, use of condoms or other methods. If a patient says that they use condoms, don't assume they use it all the time. They are at risk as well. So I want to introduce this other way of getting sexual history. This is more targeted towards primary care. You can do the 5 Ps, but this is a little bit more extensive, and it's like a little script, so you can just read off the script if you're not comfortable asking the sexual history. And it's called the Goals Framework, and this came out of New York, and it's a very good guide to kind of get the sexual history from patients. And it's not replacing necessarily the 5P model, but it gives a little bit more improved patient care, provider communications, and reduces the likelihood of bias. So you can see that? Okay, good. I thought it was really small, but it came out nicely. So you don't want to start with a component. You give a preamble that emphasizes the sexual health. So you want to say that, hey, I would like to talk with you for a couple of minutes about your sexuality and sexual health. And there's like this whole, I'm not going to go over everything in the table, but basically the goal of this is to, from the get-go, from the beginning, you just make it very comfortable and easy for the patient to have that communication about sexual health. And then in the next column, you'll see that offer opt-out testing. We just test, we get a general consent sign, and we just test all our patients for HIV and other STI. But you can also inform the patient and say, hey, I would like to test all my patients for HIV and other STIs. Do you have any concerns about that? You can say that as well. And that doesn't commit to any specific test, and you can actually order all the tests when they say yes. And then always ask an open-ended question. So you want to pick one question, it's like, tell me about your sex life. That's a very open-ended question. You could also say, what would you say are your biggest sexual health concerns? And you can also say, how is your current sex life similar, different from what you think of as your ideal sex life? So this is something to like also make it a little bit more comfortable for us to ask those questions, and for the patient. I mean, I would say, spend like maybe 3, 4, 5 minutes, if possible, if not in the first visit, in the second visit, and get the sexual health and sexual wellness conversation going. There's a couple of more. It's like listen for relevant information, fill in the blanks, how do you protect yourself against STIs, and then suggest a course of actions, like saying, hey, I would like you to give some information about PrEP, and I think this will be able to help you, and then make a tailored approach for STI prevention and PrEP for them. All right, now I'm going to move to summary of screening and monitoring for HIV PrEP. So I try to make it very simple. I've been doing PrEP for a while now, and so who are the people that we think are at risk or should be on PrEP, right? So screen to rule out the following factors that would make a person ineligible for PrEP. So for me, it's like pretty much everyone should be on PrEP, and so I try to rule out if somebody should not be on PrEP. So this is what I say. If a patient is saying they are living with HIV, right, they can be on PrEP. If they are indicated for post-exposure prophylaxis, you can give PrEP for them, right? If they are already exposed, then you're going to do PrEP for them, right? If you suspect acute HIV infection because of their history of HIV exposure in the last 14 days or recently, you monitor for acute infection, you assess their recent history, those are not the patients you would consider for PrEP because they might be a candidate actually for PrEP, right? Especially within 72 hours of exposure. Contraindication, allergy, hypersensitivity to the PrEP product. If they've been on it before and they've had any kind of hypersensitivity, those are not the candidates. I mean, these are literally the people that will not qualify for PrEP. Pretty much everybody is, as long as they're having sex. I would actually like to say one more. I would like to add somebody who's asking for PrEP, no questions asked, just start them on PrEP. That's like very important. It's like, you know, if they come in and they say, hey, I don't know if I'm at risk, but I would like to be on PrEP, they are a candidate for PrEP. So these are some acronyms that I'm going to use in upcoming slides. I didn't want to put it on every slide. So CAP is going to be for cabotegravir, then LA long-acting, FTC is emtricitabine, LEN is lenacapavir. TAF is tenofovir alafenamide, TDF is disoproxil fumarate, PrEP is pre-exposure prophylaxis, PrEP is post-exposure, creatinine clearance, and then gender-affirming hormone therapy. All right, so this is a slide that tells us about currently available systemic PrEP options that we have, and I want to present this as like a pre-LEN and post-LEN. So this is a pre-LEN approval options that we had. And if you can see, the first one was the daily TDF FTC. They came out in 2012, almost 13 years of TDF FTC. This was the breakthrough agent that started this all and gave our patients hope and us hope that we could actually do something about HIV epidemic. So what all the patient characteristics, what all the oral TDF FTC is indicated for is inserted anal vaginal sex, receptive anal vaginal sex, receptive vaginal neovaginal sex, injection drug use, pregnant breastfeeding women, initiate with double dose. So it has the most number of indications, which is cool. So whenever, I know the trend is for us to go towards the injectables, but TDF-FTC still has a role. And then the caveat is like if you have bone or renal health that is affected, then you don't want to use TDF-FTC. And so what solves that is TAF-FTC, which was the next one, right? So after the TDF-FTC came TAF-FTC, that can be safely given with a lower kidney function as well as osteopenia, osteoporosis patients, and they can also be given in insertive anal vaginal sex, receptive anal sex, question mark for the receptive vaginal sex. More about that later. ISUSA has some good data about that. And so does a study that I'm going to present later, Purpose 1. So it can also be used for injection drug use. So what it cannot be used is for a 211, or it cannot be used for pregnant breastfeeding women. So those are the main differences. Any questions on that? We're very clear about that. I'm going to talk more about TAF-FTC in the receptive vaginal sex. On demand, 211 TDF-FTC. How many of us are practicing that? All right, so this came out of the French study, the IPREGAY. So I don't know about, I know some of us are, but I don't know about Americans, but I think the French have a more definitive idea of when they're going to have sex, and I think this is a little bit more applicable in that population. I think we're more a little bit spontaneous when it comes to that, so I feel more comfortable if our patients just took a daily PrEP than try to time it and then like, oh, I think I'm gonna have sex. Let me have 2 TDF FTCs now, and then one in 24 hours later after the sex, and then another one 24 hours later. Now if you're in a white party, you might lose track of time. My Palm Springs people know what I'm talking about. So yeah, a little caveat to that, like a little careful, when we do that, recommend that you are choosing patients very carefully for this, right? But yeah, it's an option. Not with the TAF FTC, right? And then comes the every other month intramuscular cabotegravir, also known as Apretude, which is pretty much okay with everything and is an indication for everything. It's kind of like TDF FTC, plus for renal as well as bone issues. So that is pretty much universal and can be used in everything. So let's go on to this case study. I want to ask you a question. And this is a 35-year-old African-American cisgender male who came to us because he was taking TAF FTC for PrEP, but then stopped it recently due to side effects, and he wants to know if long-acting injectable options are good stuff for him. So what is our next step? So the number one is you're gonna send some testing. You're gonna send HIV antigen antibody assay and quantitative or quantitative HIV RNA assay, or you're gonna just send the HIV antigen antibody plasma test, lab preferred with reflex confirmation or blood rapid test. Okay, good. I don't expect the answer right now, but I want you to think about this. And the reason is that guidelines are changing. Guidelines are updating about testing. There's a lot of confusion about testing for PrEP. And so also Q&A, you can ask me more specific questions about that, but I wanted to bring this as a case study because we are experiencing this when it comes to what insurance is going to cover, what to do when you are actually in your clinic performing these tests and taking care of patients. So I want to present the CDC testing and monitoring for PrEP algorithms next. This was last updated February 10th, 2025. Nothing has happened in that area since then. I'm wondering why. I'm not wondering. We know. All right, so STI testing, each visit with each exposure for chlamydia, gonorrhea, syphilis are recommended for all sexually active adults who are seeking PrEP or on PrEP. We already know that. I hope everybody does that. Sometimes we're doing it every 2 months if they're on injectable. We're at least doing it every 3 months, right? Good. Also, for oral PrEP, do you want to assess the kidney function and hepatitis B serology? So you want to rule out that co-infection because you want to actually cover for hepatitis B also if they have active Hep B. And they want to assess the kidney function. This is more for TDF. And for FTAF as oral PrEP, you also want to assess the cholesterol and triglyceride levels before starting PrEP. So this is a little bit of a difference between FTAF and TDF. So for TDF, you want to do the kidney function and Hep B serology, and for FTAF, you want to do the additional cholesterol and triglyceride as well. All right, so let's see how this, okay, this came out nice too. It's really small on my screen. So this is the CDC algorithm, which was like our golden standard to follow when we started practicing PrEP. And they have divvied up this HIV testing based on if the patients are starting or restarting PrEP after a long stop, or if it's more recent. So that patient was a few weeks into PrEP and then he stopped the PrEP a few weeks before and then he came to us, so he's gonna be in the next one. But if this guy, this is a new patient who's starting or is restarting PrEP after a long time. So if the patient, so what is long time? It's 3 months. And if the patient has not taken oral PrEP and PEP medication in the last 3 months and has not received the injectable in the past 12 months, then you want to check this patient with HIV antigen antibody plasma test, which is lab-based with reflex. So that was that second B option, or blood rapid test. And if this is non-reactive, go ahead, start PrEP. If they are positive, then you want to do a confirmatory test, and then you want to actually check another HIV RNA test. And then if that test is positive, then the patient is HIV positive, not necessarily a candidate for PrEP. You want to start them on HIV treatment. But even if the test is negative, you want to ask about, this is the step sometimes we forget, that we have to ask about recent HIV exposure and any signs and symptoms of acute retroviral syndrome. I was forgetting this too. I was just going with the test, and so then I added in my EPIC template to ask about this question, and I have a yes/no drop down. And so then after I have had 2 no's on that, and that's when I moved to it, and then we know that they are qualifying for the PrEP. And so after that, if they do have acute retroviral syndrome or signs and symptoms and exposure history, then you want to check confirmatory test with HIV RNA test. If they are an antigen antibody, if any of the tests are positive, that means they have HIV and they cannot take the PrEP. So you can go to CDC website. This is still there. Sometimes the cdc.gov will show that it's not active and it's archived, and click here for archived information. You can go there. But last I checked, this was still showing up, so you can always refer to this. I don't want to go in details of it. So, and this is the other algorithm that they have, is about if the patient was recently taking PrEP, what to do, which is in the past 3 months, then you're going to send an HIV antigen antibody assay and an HIV RNA. This is where the and comes in. If a patient was recently on PrEP, you want to do both tests. And then if it's reactive, both tests are reactive, then HIV positive. If both are negative, then they're HIV negative. And then if it's discrepant, one is positive, one is negative, then there's a further testing with HIV RNA. And if that HIV RNA is positive again, then they're HIV positive. So there's a little difference. In practicality, if you don't remember which one, just do both, as long as the insurance is paying. If the insurance is giving you problems, then you're gonna have to follow the algorithm. But hopefully the insurance has picked up that CDC is not updating its guidance, especially with the newer data that is coming out, which I will discuss more, is that HIV RNA is not indicated to be done in each visit, in each injection, or each PrEP visit. So those are the things that you can keep in mind. But when in doubt, do both. But if you don't wanna do 2 tests, then at least do the antigen antibody lab-based test, in addition to the point of care test. And I know there'll be questions, so I am already expecting that. So we'll talk about that. All right. So what are the indications? So CDC PrEP guidelines say that the PrEP regimen for prevention of HIV infection in adolescents and adults is based on kilograms. So it's based on the weight. So as long as you're over 35, equal to 35 kilograms, 77 pounds, you can take PrEP. And all sexually active adults should receive information about PrEP, and so they should have negative HIV tests, no signs and symptoms of acute HIV, and no contraindicated medications. And those are the FDA approved and CDC approved recommendation PrEP regimens are the FTC TAF oral, which is daily, and FTC TDF daily as well. And then with a caveat, still with CDC does not recommend, FDA does not recommend TAF FTC for women with receptive vaginal sex, and also CAB intramuscular injection every 2 months is also indicated. So these are the 3 FDA and CDC approved agents. Remember, this is pre-Lent. Now, that date was important because since February 2025, CDC has not updated the guidelines, and Lent has come after that. As you know, it came in June. So this is just up until the CDC had the guidelines. All right, so a little bit about TAF FTC in cisgender women. I was one of the, I was not very happy with the trials, which did not include cis women, but we have now trials that include cis women. And this is a 2025 analysis provided evidence that 90%, 89% reduction in risk of HIV acquisition in cisgender women who had a biomarker evidence of taking at least a mean of 2 doses of TAF per week. Think about that. from TAF not being able to be used in women at all, or TAF FTC, to if they have at least 2 of those a week, there's 89% reduction of HIV acquisition, which is great, which makes me feel comfortable using TAF FTC in cis women for HIV prevention. So it's up to you. You want to wait for the CDC guidelines to be updated, FDA to get approval, but this data by itself, and Rafi Landovis, Dr. Dar's partner in crime at UCLA, he was one of the big promoters and also IAS USA guideline updater that he uses it. If it's good enough for him, it's good enough for me. He's a global thought leader in PrEP. So if anyone's having doubt about using TAF FTC in women, especially cisgender women who have renal and osteoporosis, we know our bones are not as strong as men's and we get more osteoporosis. So if you're thinking about, if you have a doubt about using it in cisgender women, this data should help you in making your decision. Also, because of this data, the TAF is now TAF FTC is now recommended for prevention of HIV from vaginal exposures for those in whom TDF FTC is contraindicated or undesirable. So there you go. So there is the data on that. All right, now I'm going to move to injectables. This came out 3 years ago, and I've been presenting it for 3 years. So I'm just going to have like a little one slide on our first injectable ever for PrEP use, long-acting injectable. And this is the 2 studies that got its approval for that reason. It's HPTN 083 and 084, long-acting intramuscular cabotegravir every 2 months versus oral daily TDF FTC for PrEP. This was an international, huge randomized double-blind controlled trial for phase 2, 3B in both sides. And then basically the injectable aptitude met the criteria for superiority versus daily oral FTC TDF in both trials. Anybody surprised by that? Injectable in office versus oral PrEP taken at home. You know, drugs work if we take it, right? So if they don't take it, if the adherence is an issue, then you know it's going to show less efficacy, right? So, but it was great to know that there were other options other than taking oral PrEP daily. And HPTN 083 was done on MSM in transgender women, 66% more effective than oral. HPTN 084 was totally just focusing on cisgender women in sub-Saharan Africa, and CAP was 88% more effective than daily oral FTC TAF. So not surprised there. It was definitely superior to oral TDF FTC and definitely an option. I want to remind again that 1 in 5 new HIV infections are in cis women. So we have to remember that. I want to present a little study called PILLAR. This is now 4 years since cabotegravir came out, and how did it do in real life, right? This is a phase 4 trial of HIV PrEP, and so men who had sex with men and transgender women represented about 67% and less than 1% new HIV diagnosis in 2022. And CAB was given every 2 months as a first injectable. And then several implementation studies and real-world studies have shown that LA-CAB is consistently effective for HIV prevention. And so basically they follow these patients for 12 months and say how do they do on CAB. So it shows that persistent adherence to LA-CAB. So patients want to be on injectable and they stay on injectable once they get started. And there were no cases of acquired HIV, 100% of effectiveness of LA-CAB through 12 months, regardless of the testing method. And the persistence was higher, 85% at month 6 and 72% month 12 versus reports of oral PrEP. Again, I feel like oral PrEP is great as long as they take it, right? And then there were diversity of study participants. The enrollment of Black, Hispanic people, transgender men surpassed the predefined targets. 22% of participants had no history of oral PrEP, illustrating that LA-CAP potentially expand adoption of PrEP. So some patients would just want to jump into injectable PrEP, which is totally cool. And then there were increased interactions with HCPs because of the Q2 months of requirement of getting the injection. So that is another positive findings. And so they found that in this pillar study that safety and efficacy of LA-CAP was pretty good. All right, that's like, oh, only 10 minutes remaining? Okay, well, now comes the new kid on the block. I'm very excited to introduce lenacapavir. All right, so lenacapavir, I mean, anybody who hasn't heard the term lenacapavir or it's about its recent, anybody? No, good, everybody. All right, so, I mean, this blowing things out of the park, like they say. So this is the journey to FDA approval for lenacapavir for PrEP. So August 2022, FDA approved it for treatment of HIV. Somebody remember Sunlenca? I think we have used in a few patients that had heavily treatment experience and resistance to a multiple crosses. So 2022, August 2022, and now October 2024, a breakthrough therapy designation granted for PrEP. And these are the studies that I'm going to present on the next slides. June 2025, which is 5 months ago, it got approved under priority review for PrEP. So again, CDC has not updated their guidelines. This should be in guidelines. This will be in guidelines soon, but we have enough data to definitely start talking and using it. So PrEP indication, this is to reduce the sexually acquired HIV in adults and adolescents and who are at risk of HIV, and then you have to have a negative HIV test prior to initiation with HIV RNA as well as antigen antibody, and then at follow-up you can just do the antigen antibody test. So they're very clear when this came out that does not require HIV RNA in the follow-up visits, only in the initial visit. And there's drug-resistant HIV variants have been, found if they have undiagnosed HIV infection, and this is used as a part of comprehensive prevention strategy, which we do with everything. So what is the dosing? So len dosing, we have the first, injections is a 2 1.5 ml injections plus 600 milligram, which is 2 300 milligram tabs on day 1, and day 2 just the 2 600 milligram tabs, and then continuation is every 6 months or every 24 weeks. We have the subcutaneous the same dose every 24 weeks. And anybody who has had experience with prescribing Yeztugo, lenacapavir in the clinics? Very good, Radiant. I know we have a few. So it's actually very popular with patients, and patients are requesting it, and there's a little bit of implementation in the beginning, but that's with any new injectable or any new drug. So overall, pretty good. Renal hepatic adjustment is not necessarily. There is some drug-drug interaction, dose modifications that are recommended to be done. Don't have enough time to discuss those, but make sure that you're using an interaction checker to make sure that you are using Yeztugo in patients that don't have those medication, and you can modify the dosing. So this was the PURPOSE 1 trial. This was done in cis women and with basically Yeztugo versus oral tenofovir, and it was done in South Africa, Uganda, 3 arms, and so 2, 2, and 1. So they had lenacapavir plus placebo TDF-FTC or TAF-FTC, and then one was just against FTC-TAF, and then one was FTC-TDF plus then placebo. So you'll see that the introduction of FTC-TAF in cis women, that was done here, and that is where we get the data that TAF-FTC worked in women. So primary analysis was len versus background HIV incidence, and len FTC-TAF versus background HIV incidence, and secondary was len versus TDF-FTC and len versus FTC-TAF. PURPOSE 2 was the same thing, done in cisgender men and trans women, trans men, and gender non-binary. Because we know that TAF-FTC already works on men, this was only 2 arms, len versus FTC-TDF. and same secondary endpoints with addition to study and safety. So this is what was found, right? Len reduced, look at the purpose one on the left. Len reduced HIV infection by 100% versus background incidence. And on the purpose 2, it reduced HIV infections by 96. Regardless, it was close to 100%. It's really good. It's really efficacious. Not surprised there. And injection site reactions, a little word on that. Definitely something that comes up and we have seen in trials as well as in clinical practice. There's a nodule that can develop when patients are getting this, because this is a subcutaneous, and it can be given on the ab or like the thighs, but patient can sometimes develop a nodule. Anybody has any experience in that, or any reason that anything you guys did? I know you have to ice it for like 10 minutes before you give the injection. That helps the reduction of the nodules, but otherwise the nodules do go down in size and over time, so does pain and erythema. But that is something that we are telling the patients from the get-go, that this could be a potential side effects, and be aware of that and expect it, so that it doesn't feel like they didn't know about it. Although word of caution, let the patients know. So this is a little difference between the cabotegravir and lenacapavir, and what I'm going to do is, in the interest of time, I'm going to skip that. And we just talked about injection site reaction. Mostly it's like it can last for over 6 months, and 30% of nodules sometimes did not resolve even after like 2 years. So that's something to let your patients know. If they expect it, there's a little bit less of that distress. Drug-drug interactions, again, this could be just, there's a few because of the mechanism of actions. Make sure you're already checking all the interactions before you start. And if the patient, not a bad idea to get the history of medications in the next visit. Is there anything new that was started that you can do? All right, this is very quick. Some other current research feature of PrEP. MK8527 can mix entry here. This is a new kid on the block also coming out. This is a novel NRTTI, and it's a once monthly oral PrEP. And this is currently in a phase 2 study right now, and there's gonna be more coming out. So this is an international double-blind randomized study. So we have patients age range from 18 through 65. And no previous use of MK8527 or islatravir, and there were 350 patients on this study. So this is just which dose is going to be effective, and against placebo was the main study. So we have a 3 milligram arm, 6 milligram, 12 milligram. This is once a month oral PrEP pill. This is going to be pretty cool when it gets that. So it's still going on, and primary endpoints were safety and patients discontinuing due to AEs. So this is what so far, the conclusion is that this is done in patients at low risk of HIV exposure with 6 consecutive oral monthly doses, well tolerated, and the planned phase 3 studies will evaluate the efficacy and safety. I don't know if it's, you guys are, very smart people, are actually recruiting. Well, hey, yes, we are very excited. Potentially we'll be partners in bringing the research to the Orange County area, and this is something that, patients who don't want injectables, this will be a nice option to take a monthly oral. All right. Dapivirine ring, this is an intravaginal silicone ring developed by international partners from microbicides. Aspire study showed 27% reduction, ring study showed 31% reduction. I don't know, we have more effective PrEP options. I don't know how much of that will actually show up in the US. And these are some other long-acting multipurpose prevention technology, MBTs. These are injectables which are already out, subdermal implants that are being seen in production, contraceptive plus HIV prevention together. These are just a list of all the things that's going on. And that's it. These are my references, and I am, I think, on time.
Let me just start off by asking a question that came on the chat. Is HIV PrEP covered by insurance? And does ADAP cover PrEP for HIV negative partners?
Yes and no. So HIV is covered by insurance prevention, but ADAP does not cover anything other than HIV positive visits and labs.
So one of the things I was going to share is that we just started using Len for PrEP in our STI clinic, and I was sharing with Dr. Gupta and Dr. Reed. I've had patients turn me down because of the nodule. And so one of the things we were talking about is I'm not calling it a nodule, I'm calling it a bump or a lump. And Dr. Reed was saying, like in Spanish, when we're counseling, it's called una bolita. Like, so it's small, it's cute, it's like a little ball.
Is it?
No, I mean, but the thing is I have some, and I actually went on Reddit because, you know, why not? And there were some guys talking about the lump or the nodule, and I have some pictures if you want to see them. So the day one, he said one of the people had a lump as big as a lemon. It was really, really big. But then by day 6, only he could feel it, you couldn't see it. And so, but I think it's good to tell people, like, it might be there until your next injection, it's highly likely. And then people ask me directly, is someone gonna be able to tell when I'm wearing underwear or a swimsuit? And I can't answer that question because everybody has a different kind of reaction. So, yeah, I'm having a hard time selling it. I want to, you know, and then we have some people who really are like, get me the injection, I don't care. So I've seen everything so far.
It's concerning. I didn't realize you wrote that 30% of people may have it a year later.
Just back to the PrEP question. So as there is HIV medication and other medications related to HIV, opportunistic infections, through the state AIDS drug program, there's that's called ADAP, AIDS Drug Assistance Program. There's PrEPapp, or PrEP Assistance Program. Just wanted to make sure it was clear that patients can get PrEP care and treatment of STDs, and for a select group of folks can get actually the PrEP medication covered by the state of California if there's reasons why you can't get it.
They have to get their own account though, right? Like their partners have to get their own.
PrEPapp provider, yes.
Any other questions?
Thank you for that talk. I think what Dr. Park was also saying then tied into my question. What are your thoughts on where you see the future of long-acting PrEP? Do you think lenacapavir will overtake Apretude, or kind of try to see, especially in like a clinic setting where we may have some limited access, like in an ID clinic? We're seeing patients back every 2 months right now for cabotegravir. Lenacapavir certainly seems appealing from that standpoint anyway.
So if it's for the lack of office visit every 2 months, Apretude versus, So I've worked in different settings. I've worked in very busy clinics, and I work in a university setting, and then I'm not saying it wasn't busy. It was definitely challenging, but a little bit longer appointments. And then now I'm working in an FQHC setting. So you can modify your practice. So if you're every 2 months, you can see an Apretude injection patient. You can see them every other visit. And then you see them today, and then in 2 months you can do a nurse visit where you have everything being done in the injectable, being given by whoever gives the injectable in your office, and the labs are being done as like a non-billing office visit encounter. So that care of patient is being done, patient is getting the swabs and everything, but you're not seeing them, and then you're seeing them every 4 months, but the care continues. So every alternate with nurse visit, that's one of the options. And to answer whether it will overtake Apretude, if he has to go overtake, that's time will tell. It's still new, but there's definitely a lot of interest. But we also want to see to give all the options to patients, and you have patients on whatever injectable or oral PrEP they have. Introduce them to the new option and let the patient decide. And nodule is a thing for sure, whether you change the name, call it a lump or, right? Call it a lump and make it, but more important is you let the patient know, like, listen, for this you have to come every 2 months and commit to, labs and injection every 2 months in an office setting. Other one is every 6 months, but then there's this nodule, there's some drug interaction. So let the patients also be part of that decision making. And yes, I think both are great options. So we'll see.
So with lenacapavir, there would be no clinical monitoring for 6 months?
So in our practice, what we will do is have them come in 3 months, kind of like we do for oral PrEP for at least the STI screening. And if they've had an exposure to HIV recently, or they're positive for screening for any STI, I would throw in an HIV test there also in between those 6 months. And just not necessarily do HIV testing every 6 months just because they're on Yeztugo. So every 3 months we want to see them. If you can't see them, well, you will be able to see them. You can have an appointment every 3 months. But at least get the STI screening done in 3 months, even if you don't see them.
May I?
Yes.
I wasn't familiar with the PrEP ADAP equivalent. So who has access to it? I'm particularly concerned about adolescents who do not want to disclose to their parents. They may have insurance by the parents, but they don't want to disclose. Can they go?
She's over there.
Here. Chris.
Yes.
So the PrEPared program is mostly set up for covering the cost of the visits with your provider, the medical testing, the STD screening and treatments. For patients who are on someone else's insurance and they don't want that person to know that they're on PrEP, they're called confidential cases. And in that case, the state will pay for the PrEP medication, be it Descovy or Yeztugo, which that was approved, I think, just this week. But otherwise, patients have to get the drug from the drug company, through their expanded access program, or excuse me, it's an advancing access program, the Gilead program for Descovy and Yeztugo.
And I have Dr. Dewey here. Maybe you can let them know about the options that Radiant also offers if you're underinsured or uninsured. So if you want to say a few words.
Can I get the microphone?
There's many options.
That's a great question. So I'm pulling up right now the PrEP app chart for qualifying. So if you have any confidentiality issues, you automatically qualify. If you don't have any confidentiality issues, you have to have a certain income. And don't quote me on this because I don't have it right here, but the last time I checked, I think it was about 400% of the federal poverty limit. 600, thank you very much. And PrEP app is actually very easy to qualify for, and I believe they also cover Apretude, which is great. So I'm hoping that they might qualify for or cover lenacapavir very soon.
Thank you.
And in Orange County, because the Radiant is an FQHC, if you are uninsured, if you have any patients who are uninsured, please send them over and we can take care of them. We have a lot of resources.
Kids got infected heart insurance in California, but they're partners. So that's...
I'm sorry, can you repeat that?
The children up to 21 have access to drugs and care through California, but the partners don't.
Yes.
So that's why I was asking.
Yeah, so if you're if you're a minor with confidentiality issues, you can qualify for PrEP app, and their partners would too, if there's any confidentiality concern.
Thank you.
Thank you. I think that will be our last question. We are going to go into our lunch break. And remember, see the exhibitors who are also talking about HIV prevention, all these medications we just talked about today, as well as treatment.